A 52-year-old male patient was told that he needs tooth number 9 out. It was traumatized earlier in life, and it has a problem called external resorption. Does the tooth need to come out? What can we do in order to be able to save the tooth? That's what we're going to talk about today in practical treatment planning. The patient is somebody that I know, and I've known him for many years. I didn't know he had the problem when he was seeing another dentist. He was told that he needs the tooth out, that it has external resorption. This is better known as external resorption from the osseous crest, and I want to thank for this education Dr. Richard Schwartz. Dr. Richard Schwartz is an endodontist in San Antonio, Texas. If you have a chance to see anything that Rick does, he's going to show you how lots of teeth can be saved. The patient has a little bit of soreness around the gingiva of tooth number 9. You can see that there's a difference in the characteristics of the gingiva of tooth number 9. It doesn't bother him very much, and this is something that was discovered during x-ray. External resorption comes in 4 different varieties, or is classified in 4 different ways. It was classified by Heathersay, and if you take a look in the comments, you'll get a reference for Heathersay. I encourage you to read this because it can be very encouraging to you with regard to external resorption. Let's take a look at the periapical, and you'll notice there is a pulp canal in tooth number 8, but there is no pulp canal in tooth number 9. If we take a look at the CT scan, we'll notice there's no apical lucency on number 9. That's quite encouraging. Let's take a look at this part of the CT scan and notice the area of lack of contour in the facial aspect of the root surface of number 9. This is an area of external resorption from the osseous crest. Now, how does this work? If we take a look at this diagram, you'll notice ordinary periodontal ligament space. You'll see the tooth, you'll see the bone, you'll see the periodontal ligament, and I've drawn in the gingiva here. What happens in external resorption? And what we think occurs is that as a result of trauma, the patient loses the periodontal ligament. And that's what you notice here, a loss of the periodontal ligament at the osseous crest in the facial aspect of this diagram. In that way, then, we have bone growing right against the tooth. Now, bone has ordinary turnover, osteoblast, osteoclast. In this case, the osteoclast recognizes the dentin the same way as it recognizes the bone, and the patient loses dentin. So essentially what we have is osteoclastic resorption of the dentin, and it leaves a defect. When we look at this area clinically, we'll see that this area doesn't probe very well. In fact, it might hurt a little bit because what we have then is organic material in the area of the defect, and the defect itself is a bit bloody. When we're evaluating this, and notice we're evaluating this in a number of different ways, but the CT scan is really valuable here. We're looking for the depth of the defect. We want to see whether the defect has approximated the pulp canal. In this case, the pulp canal is not there. The pulp chamber is gone. We then look for an apical lucency to see whether the tooth might be abscessed. It is not. So therefore, we can classify this as a class 1 or a class 2 defect, an area that we could possibly treat, perhaps without endodontic treatment. How do we treat this area? Well, the idea is that there is organic material, and we want to stop the organic material from eating away at the root surface. So we'll reflect a flap in this area, and we'll gain access to the organic material. Now, the organic material is best dissolved with trichloroacetic acid. Trichloroacetic acid is something that you can have made at the pharmacy. It's quite caustic, and so if you're operating using this material, you have to make sure the area is isolated quite well. It can burn. It will burn the surrounding tissues. And what we'll use is a cotton pledget filled with trichloroacetic acid, and that will dissolve the organic material. The organic material then is gone. It's then a bit brownish. We'll rinse away the brownish material, and so what we'll have is a cavity in the tooth. Now, this cavity in the tooth is not caries. This is as a result of the osteoclast. We'll rinse out all of the organic material, and then we'll fill the area with Gerastor, and then we'll coronally reposition the flap. If we have a class 1 type of case, then we have a better than 80% chance of saving a tooth like this. If the patient has symptoms later on, then endodontic procedure might be done. But given the fact that this defect does not approach the pulp canal and we see no evidence of apical lucency, then all we're going to do is follow this up radiographically, perhaps every year, and make sure there is no apical lucency that appears. If there is none that appears, then this is a solution for this problem. Understand that when we're treating an area like this, the opportunity for ankylosis is pretty high. After all, there was ankylosis here. There's bone growing right against the root surface. How easy is it to get a tooth out that's ankylosed? Yeah, not very easy at all. And our difficulty here is not just removing the tooth, but how much of the bone can we preserve as we carefully remove this tooth? The bone will likely need to be reconstructed in order to be able to place an implant, a good aesthetic implant with proper emergence profile. According to Hethersay, the opportunity for resolution in a defect like that is quite high, and therefore it's to our advantage, the patient's advantage, not to have a reconstruction, not to have a gingival and bone reconstruction, but to retain the tooth in this manner. When do we extract a tooth like this? It really has to do with the amount of damage that's present. If the tooth is about ready to break off, we have to remove the tooth. If the patient is symptomatic and we feel that it's going to be even further compromised if endodontic treatment is done and the tooth is going to crack, well, that may be a reason for the reconstruction. In an area like this, we're really measuring the amount of damage that's been done to the existing root surface. And if that damage is minor, in a case like this, it is minor. I know it seems a little bit major to you, but in terms of how much damage has been done within the diameter of the tooth, it's still, 25%, 30%, something like that. Then our opportunity of saving this tooth is quite high, and therefore we retain a tooth like this. How do we follow up a tooth like this? Well, we won't probe it for at least 6 months. We want the opportunity for the gingival tissue to regrow and to get some kind of attachment here. An attachment against Gerastor, although we've heard and we've seen that people talk about attachment to Gerastor, I wouldn't trust that. But I also would not probe it very deeply, and as we don't want to disturb whatever attachment may occur. If the area is healthy, if the area is not bleeding, the patient is able to take care of it and stay symptomatic, then that's the treatment for now. And we continue to follow the patient up and make sure the patient is doing okay. As long as the patient is asymptomatic, we keep the tooth exactly as is. We can always do the next step. We can always extract. We can always reconstruct. And if we can delay this, maybe delay this forever, this gives the patient the best opportunity for good aesthetics, good function, and minimal traumatic surgery. What do we say to the patient? I talk in terms of percentages. You know, in dentistry, we're very much into black and white, aren't we? But there are a lot of gray areas. In this series, in practical treatment planning, we're talking about gray areas. So I talk in terms of percentages. It's not promises, it's percentages. So if we follow the 80-20 rule, I'm happy to say I think we have an 80% chance of saving this tooth over a 10-year period of time. That's backed up by the literature. The patient understands there's a 20% risk, and the 20% risk is one that person's willing to take. I think we also weigh the risk against the amount of work that's going to be necessary in order to be able to reconstruct. So understand that if we extract this tooth, a lot of bone is going to come with it. So there's going to be a major bone graft that's necessary in order to be able to reconstruct and place an implant in that site. And the implant may be delayed by as much as 18 months before the patient has a tooth there again. If the patient understands what the risks are and also what the cost would be of an implant reconstruction, then he can make the best decision for himself. Usually the patient is going to pick the route that's going to be the least difficult route. Understand that there are costs involved. Also, if the patient compares the cost of the reconstruction to this particular procedure, the treatment of the external resorption, the cost is far less. So the patient will pick this, understanding that there's an opportunity for success and there's also the chance of failure. And this, of course, is written in the informed consent that the patient signs as well. If you want to see more about how we can save teeth rather than do implants, take a look at this video.